Hello and welcome. Thank you very much for that moving and really important session. It was helpful, it was difficult, it was honest as well as hopeful, and thank you all for sharing and being so open and inspiring. It reminds us also how critical and important the work we're all engaged in is. I'm excited to introduce our next session, which is to provide a broad international overview on where we stand in our understanding of PSC. Our first speaker will be Dr. Richard Green, who's a professor of medicine in the section of hepatology at Northwestern University Feinberg School of Medicine. He graduated from Duke University Medical School with a degree in medicine, and he undertook his internal medicine training at Northwestern University. His gastroenterology and hepatology fellowship was here at Brigham and Women's Hospital at Harvard Medical School in Boston, where I am. So delighted with that, and that makes us sort of family related in some way. And prior to working at Northwestern, he served as an instructor at Brigham and Women's Hospital at Harvard Medical School. And now he's a professor of medicine at Northwestern University, Feinberg School of Medicine. And he has been active in clinical, translational, and basic research, investigations of cholestatic liver disease, fatty liver disorders, and PSC. And he's been productive, particularly in the area of mechanisms of cholestatic liver injury and repair, which is a critical area. Our next speaker will be Dr. Tom Karlsen. He's a leading PSC researcher. He directs the Norwegian PSC Research Center, or NOPSC, at the University of Oslo, where he is a professor of medicine and has been involved in numerous important research efforts in PSC. His efforts are focused on multi-omic approaches to apply the current state-of-the-art techniques to understand the disease processes underlying PSC. And as important as his productive research is, equally important is that he's created a spirit of cooperative collaboration in the PSC international community, starting with the International PSC Study Group, which he helped found, or really founded, and which has grown to be an important hub for productive multi-center research in PSC. At the Resnick Center, we're delighted to have a project that's underway in collaboration with NOPSC. Tom understands that research in PSC is a team effort and has helped lead the PSC community with this open, collaborative, sharing spirit, which is critical to helping the community make essential progress. And I'm the other speaker. You've all met me. I'm at Brigham and Women's Hospital and direct the Resnick Family Center of PSC Research, as well as director of Brigham and Women's Crohn's and Colitis Center, and though I'm stepping down from that so I can devote more time to PSC. Now turning it over to you, Dr. Green. Thank you.
My name is Richard Green. I'm a professor of medicine at the Northwestern University Feinberg School of Medicine. And I'd like to talk for the next few minutes about fibrosis and fibrotic mechanisms in primary sclerosing cholangitis. As most of this crowd probably knows, PSC is a chronic liver disease in which the bile ducts, both inside and outside the liver, may become inflamed and scarred. Bile ducts are narrowed or blocked, and bile builds up in the liver and causes further liver damage. It affects about 5 to 16 per 100,000 individuals. It's associated with inflammatory bowel disease, most often ulcerative colitis, and it has a presumed autoimmune disease pathogenesis, but the actual pathogenesis is unknown. Here I'm going to describe the name primary sclerosing cholangitis. Now, primary because it's not secondary, and there are secondary forms of cholangitis. If you're obstructed from a stricture or a stone or anything else that causes chronic bile duct obstruction, you can get secondary sclerosis. Sclerosing, I'll come back to, and cholangitis is inflammation of the bile ducts. So sclerosing is a pathologic hardening of tissues, especially from overgrowth of fibrous tissue or increased in interstitial tissue. That's defined by Merriam-Webster. It's a sine qua non of PSC. The sine qua non literally means without, which or not, but it's an essential condition, a thing that's absolutely necessary. I know this is an international meeting, so that's the Oxford Dictionary. I'd like to go through the anatomy of the liver. The liver is here. It's got two bile ducts, a left and right hepatic duct, which comes into the common bile duct and actually merges with the pancreatic duct. And any of the large bile ducts can be affected in PSC. There's another form of PSC called small duct PSC, which I'm not going to discuss further. And if there's an obstruction anywhere in the bile duct, then the liver cannot have adequate flow of the bile into the gut. It can back up, and high levels of bile acids or bile salts will cause further liver injury. As can be seen here, this is just a schematic of PSC, where you have narrowing, stricturing of the bile ducts. You'll often have dilation above the stricture, and it is quite diffuse and throughout the liver. Again, this is an MRCP, an MRI, focusing on the bile ducts that can show a similar pattern of strictures and dilations. This cartoon shows a normal bile duct, while this cartoon shows a sclerotic bile duct in a patient with PSC. It would look like this, where there's fibrosis all around the bile duct, including the strictures. Well, this shows severe fibrosis. Severe fibrosis is called cirrhosis, and this is a normal liver and a cirrhotic liver. And as you can see, this can be caused by any form of liver disease, including PSC, and you have a nodular type of liver. It's not smooth, and that's due to formation of scar. If we look microscopically, you can see that the final common pathway for virtually all progressive liver disease is fibrosis and then cirrhosis. And we often will stage the degree of fibrosis from 1 to 4, although there are other staging systems like the E-shock from 1 to 6. And you can see here a normal liver, which has a nice architecture. And these are trichrome stains that show increasing amounts of fibrosis, F1, F2. By F3, we get what's called bridging, not full nodule formation, but bridging fibrosis. And cirrhosis is defined by the formation of nodules. PSC, on the other hand, can have another unique form of fibrosis because it's a primary fibrotic disease. And it's not like many other liver diseases, which the fibrosis is only secondary to the liver injury. As you can see here, this is onion skinning or concentric fibrosis. You can picture an onion cut on edge, and this is classic for a bile duct in PSC. Well, how does research affect clinical practice? Well, there's many forms of research. There's basic clinical and translational science. Translational science is essentially laboratory bench to bedside. There's computational, there's genetic. Computational includes AI, and I think that will be very important in all liver diseases in the future, as well as epidemiology, outcomes, health disparities, quality assurance. But what I want to emphasize is now virtually all good research is done in interdisciplinary research, combining many of these different types of silos of research. Well, how does research affect clinical practice? First of all, medical research is unfortunately usually a slow process. And our goals and choices on how much resources we should give to a different form of research stems from our limited resources. Now, these are theoretical examples, but to cure PSC, it may take a moderate to long period of time, perhaps decades. To treat PSC and prevent liver digression may be considerably shorter. And patient-based or quality assurance or similar types of research are much more short. So this is not absolute. You can have a cure hopefully much quicker, but there tends to be a different time lag depending on the form of research being performed. I just want to show an example of a long-term benefit of PSC research, and this has actually progressed over 2 or 3 decades. This is an ERCP, which is an endoscopic test where you inject dye into the bile duct and visualize the bile duct. And this arrow shows a very fine stricture in PSC. There's hardly any dye going through here, and you can see dilation above the stricture. When I was in med school, really there was not good ERCP interventionals for PSC or many other biliary diseases. And if I look at my textbook, and I don't have it anymore, we learned that the colodocal duodenostomy procedure was how we would deal with strictures. It's a surgical bypass of the distal bile duct that can drain the bile ducts into the gut. When I looked at this online, I found that unfortunately, I had the third volume, but the first volume is now selling for 5,100 pounds. So I should have saved it. Anyway, this is the long-term benefit of research studies. And as you can see here, here's an ERCP shown before. You can put a balloon up, or often stent. Generally ballooning, dilating a stricture is the preferred methodology. But either form of intervention can be done at the endoscopist's discretion. This has led to essentially a plan of management for PSC and biliary strictures, where you can do an ERCP, preferably you can do a balloon dilation, but if not, you have other opportunities and other palliative and hopefully curative measures. And this just goes to show that long research building on top of each other can change clinical management. Well, what causes fibrosis or scarring in the liver? First of all, it's due to multiple cells. This is a stellate cell. This is a myofibroblast. They lay down collagen and could cause scarring. Obviously, hepatocytes, which are the primary liver cells, or the bile duct cells, the cholangiocytes, can also interfere, as well as immunologic cells. And there's big crosstalk between these. Now, fibrosis is actually a normal reparative response of the liver or to the body in response to any form of injury. If you don't scar and you cut yourself, you'd bleed to death. But there needs to be a balance of fibrosis formation and degradation. As can be seen here, this is very complex. The specifics are not important, but fibrogenesis is going along with fibrosis degradation, and it's really a nice balance that keeps the liver healthy. However, if fibrosis formation could be excessive, you do see fibrosis and then cirrhosis evident by this nodule formation because it exceeds the fibrosis degradation. On the other hand, there are mechanisms to increase the fibrosis degradation. And these are druggable treatments for fibrosis and PSC, either to reduce formation or decrease or increase degradation. Now, why is this not done thus far? Well, people have been looking, and thus far we're not yet successful. Again, there's multiple issues, multiple different cytokines and other mediators, and that's shows how complex the etiology of fibrosis is. So I'm going to show a few slides outlining some posters and talks at this symposium. I can't do the talks do justice, please see them, but I can overview them, kind of commenting on the type of research. So one thing we have is drug repurposing. You take a drug that's FDA approved, for instance, and you repurpose it in the process of uncovering a new indication and applying a failed or abandoned compound for different diseases. This means you take an FDA approved drug, the safety has been shown, we know the dosing, and you can apply it to another disease like PSC. And there's actually two basic science posters looking at idebenone and aprepitant. These are actually FDA approved drugs for non-liver indications. And as you can see here, this is a study by Dr. Jang out of UC Davis. SHC inhibitor idebenone is beneficial in the MDR2 knockout mouse. Well, many of these will show the MDR2 knockout mouse. This is a mouse. it's lacking a gene, and it gives a histology. It gives a very similar to what we would see in PSC. The defect in the mouse is not the same as PSC. It's imperfect, but it does give very similar findings in the liver and bile duct. And as you can see here, this is the pathway that they've shown is important in fibrosis. And by giving it to this mouse, you can see you do improvement of the liver function tests going down. And therefore, they are looking at this in the MDR2 model. If this proves positive, then they can hopefully begin clinical trials. Similarly, there's a study out of Indiana by Dr. Korzenik on the apriptant, which is a NK1 receptor antagonist. Again, the details are in the poster, and similarly, they're testing the MDR2 mouse, showing efficacy and preventing liver damage will be the what's needed in order to transition to clinical trials. I want to talk about stem cells and organoids. We all hear about stem cells. This is a cell that's able to develop into many or all cells in the tissues. Pluripotent, sorry about the 9. Pluripotent means this cell is totally undifferentiated. We can differentiate it into liver cells, biliary cells, etc. An organoid, on the other hand, takes a stem cell and grows it into a multicellular tissue or tissinoid or organoid. In this case, it could have components of liver or bile duct. And there's a study here by Dr. Ferruto looking at modulation of, this is essentially causes fibrosis, interacting cells using PSC cholangiopathy model for biliary organoid. And as you can see here, and please look at her poster for more detail, you can see that this is a nice model. Basically, this technology has come along in the past 5 or 10 years and is very powerful. Again, to investigate the other causes of PSC and fibrosis, we want to understand the pathogenesis, identify important genes and proteins, and target these for novel treatments. Again, this is the complex pathway. It's actually a simplified pathway. And I'm going to go quickly through about 5 posters. This is a poster out of Indiana by Dr. Zhao that shows IL-33, which comes from mast cells or cells that live throughout the body and the liver, can cause injury in PSC using this mouse model. Similarly, if you have a knockout mouse, which means this is missing in the liver, this microRNA, which is a gene regulator, it reduces liver injury. Here's the control, but in the knockout mouse, you see much less injury. This shows that there's a gender difference, perhaps from estrogen in liver injury for the MDR knockout mouse. They treat with a estrogen-like drug and show differences in the propensity of disease. Here we look at Melissa Kriegermeyer from Northwestern. We have a double knockout mouse, which means we can combine a knockout MDR2 mouse with what she is interested in is called XBP1 and show that by double knockouts, you get more injury, implying that this gene is important for preventing injury. Again, another mast cell mediated neurokinase signaling. TGF beta is an important fibrosis gene, again in the MDR2 mouse. And again, I encourage you to see the poster. Finally, TGF beta again can ameliorate cholestasis in this mouse model. And as can be seen here, you can change the propensity to develop disease depending on TGF beta 1. Back to PSC. Well, these are all promising research, and how does this really apply to you, all of you in the audience? Well, there's a couple takeaway points. First of all, fibrosis scarring is important in the development and progression of PSC. There are unfortunately currently no effective therapies for PSC to prevent fibrosis, but ongoing research in many institutions, laboratory-based, translational, clinical, genetic, microbiome, computational AR, are ongoing to provide better therapies. In the future, these These and other techniques can be used to provide potential paths to or pathways to new therapy. And again, prior research in PSC, such as what I showed you in the beginning, can improve clinical management and improve the care of patients. And using these complementary and novel research techniques, state-of-the-art techniques, we hopefully can develop safe and effective new treatments or cures for primary sclerosing cholangitis. So thank you very much.
Thanks again for this kind invitation to give this presentation here at the PSC Partners virtual meeting of 2022. I'd very much like to be with you, and I'm sure that all of you would also have liked to be together. But this is how it is, at least for some time more. And what I will try to do here today is to provide you with a brief update on what is going on in Oslo and Bergen as part of the Norwegian PSC Research Center portfolio. You may look into the details. The annual report should be online by now, both from the Oslo-based activities and also for the scanned PSC, which I will talk more about later, which is based in Bergen. I want to dwell a little bit before going into the details on this figure, and many of you will have seen this before, both in my presentation and maybe also in other presentation. It's a little bit of a schematic diagram of what happens during the development of PSC. It runs like a clock, starting with some genetic factors, some environmental factors. We know some of the genetic factors. We know a few of the environmental factors, and somehow these initiate the process, which leads to the development of the typical strictures and other aspects of primary sclerosing cholangitis. What's happening in the early phases here, we're not entirely sure, but we are learning. We know from the genetics that probably the immune system is involved, somehow reacting either to a very specific antigen or to more non-specific factors from the gut. The gut is likely important somehow, as we will also come back to. And this cross-talking between the various immune factors, bile factors, also cells driving development of fibrosis leads to an orchestra which drives the development of PSC. Depending on where you do your research, you would have a different type of emphasis. If you work in Amsterdam or in Vienna as a PSC researcher, you would be very interested in bile and the bile bicarbonate umbrella and the physiology surrounding bile and its influence on PSC development. If you would be working in Oslo or Hamburg or Birmingham, you would be very interested in the immune system and how this works to drive the development of PSC. And yet in other laboratories, for instance in Paris or in London, you would be more concerned about the fibrosis and the development of fibrosis in the development of PSC. Regardless of the order of events here, somehow this is the final picture. And I will try to explain to you a little bit about how we have made our priorities in this overall representation of PSC. We worked for many, many years, over a decade in genetics. This is in many ways a decade of work in a single slide. We found many, many genes. Some of them I've presented to you in previous PSC Partners meetings. And in a very summarized way, the sum of all these insights is that the immune system, here represented by a T cell, in which many of these genes are active. T cells are particular immune cells. And taking from the genetics, clearly there is a strong immune component to the disease. And this has led to us having an important emphasis on immune function in many of our activities. Then I will try to take you through a little bit of the different activities. We have now quite a robust group structure at NOPSC. This is the experimental group, which is led by Espen Melum, whom I think you would also have met at some of the PSC partners meetings. And of course, I cannot talk you through all the projects in these groups, but I will just give you a few highlights so that you can have a flavor of it. This is work from Sajun Jung, who published a paper last year, which some of you may have seen, on the role of a particular genetic mutation in a Swedish family with PSC. And she detected this mutation, which seemed to be quite private and which led to PSC development, both in the PSC family, but also in mice, when she introduced the same mutation into the mice. Now she's working further from these findings, and what she saw during the project that she now already published was that in the normal mice, if you put them into a context which would develop cholangitis, a very toxic way of inducing cholangitis. The normal mice, they react in the beginning, but then they somehow adapt to the injury. Whereas the mutated mice, the mice who have the same mutation as these patients, they will actually not adapt, and they will progress in their cholangitis and their disease. However, if you introduce these T cells, these immune cells that I already hinted to, somehow even the mutated mice, if they get T cells which come from the normal mice, actually the mice becomes able to resolve the injury in the same way as the normal mice. And what she's doing at the moment is trying to understand, why is this? Why is it that, what behavior of these cells is it that leads to the fact that actually these mice can tolerate the ongoing injury? And of course, if we can understand this, this would certainly be an opportunity for us also to allow human people with PSC be able to more effectively deal with an ongoing injury in the bile ducts. Then we have other projects. Here are some projects driven by Brian Chung. And, you know, in many ways, science is technology driven. The technology was what allowed us to do the genetic studies. Now we have other technologies. We can do characterization at the single cell level. We can map these disturbances that we detect into the liver, not only in 2D, but also in 3D. And we can incorporate all this information, verify it, and come up with very sophisticated suggestions of PSC biology. Brian is already having some interesting observations here that he's currently working on into multicellular models. And his ultimate aim is, of course, to take these technology insights and the ideas that we gain from applying these technologies into possible therapeutic applications. We're not only using technologies that others develop. For some areas in PSC, actually there is no off-the-shelf technology that you can use. One such technology that Anna Frank here is developing at NOPSC is a so-called bile duct on a chip. So what is this? What she's doing is she's taking bile duct cells from livers of explant livers coming from liver transplantation, and also from mice. She can use both human cells and mouse cells, and she allows them to grow in a tube, which is nurtured onto this complex chip, which is shown in the picture here. And this is already somehow working. And what she's trying to do at the moment is introducing other cell types, immune cells, fibrotic cells. There is no limit to which type of cell you could think of. And the idea here is really to build a system where you have a mini bile duct, which you can study both from the human side and from the mouse side in a very rapid way. If you are to study this in mice, mice grow slowly. There are various technical barriers, and of course, this may actually allow us to do certain things that we previously could only do in mice much, much quicker using this bile duct on a chip. And we can use it for screening for drugs that may be effective in changing certain characteristics of the cells. And we can also use cholangiocarcinoma cells on these chips and test which drugs are effective in an individual patient. So we are quite excited about this, and I think this somehow summarizes the opportunities of the experimental group. Johannes Hov is leading what I call the big data group, the genomics and metagenomics group. I think he has also spoken at these meetings before. And his emphasis, here represented by Peder Brodland, who made this nice figure, is this biochemical factory of the gut, which produces a wide range of metabolites, molecules, which are somehow passing through the liver on its way to the rest of the organism. And given the disturbances that we have in the bowel of people with PSC, certainly many things are changed, and there are many opportunities for these changes to influence the bile duct in the liver. And this is what he's trying to understand. He published a quite, I would say, remarkable study last year in gastroenterology, where he showed not only what we already know, that in PSC patients, there are fewer types of bacteria than in the normal gut. So that means that there are fewer functions available in the PSC intestine than in a non-PSC intestine. And he could show how this influences a wide range of molecules, some of which you may be familiar with, amino acids listed here. But there is also this example on the top here with vitamin B6, which is produced to a lesser extent in PSC. Of course, this may be for a reason. So it's not given without saying that we should start supplementing with vitamin B6, but it could also be that this shows some beneficial effects, and we need to study this further. And this is what is currently ongoing. And we are studying this not only in the patients, because by the time that we make a diagnosis of PSC, there will already be changes in the bile ducts, and there will be a lot of disturbances to our observations, also in the bowel and in the microbiome. But we're studying also after liver transplantation, and we're comparing the findings after liver transplantations with the findings before liver transplantation to try to figure out what's really the fundamental things that are specific to PSC and that may be somehow targeted and drugged, as I'm illustrating here in the figure to the right. It's a quite complex figure, but it shows just that there are all these many things that are coming from the gut. There are also things coming from the liver to the gut. And all of this somehow goes into the organism, and it's all connected with the exterior. And if we think about this bug factory somehow influencing PSC, either causing a more severe PSC or even causing PSC in the first place, certainly if there are molecules here, which there are too many of, we can try to take them down. If there are molecules here that are too few, that there is too little of something, we can even think about substituting it. So we think that this avenue that Johannes and his group is carving out with the microbiome studies is hugely interesting. The last group or the last groups you can see here, there is one clinical group in Oslo led by Trine Folserås, and there is one clinical group in Bergen led by Mette Westerhus here. And what they are focusing on is this phenomenon of trying to predict. They're trying to look into the future of the individual PSC disease and to tell us what is going to happen. And this is quite challenging, as you would all know better than we do. PSC is so different from patient to patient. Symptoms are going up and down. IBD is going up and down. But underlying all of this, there is this somehow continuing process in the bile ducts, which somehow leads to complications. And in some patients, after many, many years, also to liver transplantation. And we're trying to figure out what is really the best way to predict all of this. Trine is focusing on the most dreaded complication of PSC, CCA, and what she wants to do is to try to find the easiest possible way of detect cholangiocarcinoma at the curable stage. She has found markers in tissue. She has also detected these in brushes taken from the bile ducts. These are all quite challenging methodologies. And she's now able to also measure the same molecules in bile, which is even more easy. And she's trying to validate this for clinical utility. Hopefully, the future of all this will be that of even possibly measuring these molecules in blood. However, this is still quite difficult and maybe still some way ahead. What Mette is doing, she's taking all the different biomarkers that we've found over the years, and she's now exploring the utility of these biomarkers in a big cohort of PSC patients from Norway and Sweden, which we are currently following with the support from the Halloran Family Foundation. There are now more than 650 patients in this initiative. We will aim for the double, and after the pandemic, things are picking up. And we're looking at this both from the perspective of trying to understand how to predict PSC, but we're also trying to understand how the biomarkers can serve useful in clinical trials, which are also being run within the SCAN PSC cohort. So this is the team working for you, working to try to figure out PSC, coming from many, many angles, and really now trying to make a difference. And I typically like to show also this slide, because there is a reason for hope. There are examples of cure. It's a long road, probably longer than we would wish for. This is the example of hepatitis C, which also was awarded the Nobel Prize, where they found the virus in 1989, and 25, 30 years later, we're actually now able to cure the disease. The disease is no longer a problem. It tells us that we have to be patient, but it tells us that it's also possible. And what we're really trying to focus on at the moment in PSC and in Oslo is to bring together all the research activities that I've shown you some examples of here to really bring them into the clinic. We want to have a drug. We want to have a tool for detecting cholangiocarcinoma. We want to find PSC as early as possible, and we want to be able to measure the activity of PSC. And we will engage internationally in collaborations with industry to try to make this possible for PSC as it has been possible for hepatitis C. So that was everything that I was able to share with you in these scarce 20 minutes. And I hope that you will have a nice meeting onwards, and I hope to see you again soon somewhere around. Thank you very much.
Hello and welcome. Thanks very much for being part of this session. What I wanted to discuss for the next brief session is to really dig down a little bit into this connection between PSC and inflammatory bowel disease. And really it's clearly a close relationship, but are they siblings or yeah, there's an association, but they're more distant cousins. And what do we learn from it, both in terms of the behavior of the disease and what to expect, how they each interact with each other, and also then therapeutically, what could we learn? And I also want to focus a little bit, because that's really the nature of what we do, both in this conference and otherwise, is how does that inform research, and what are the research questions then we need to learn from it? And just to tell you a little bit, again, myself, I've lived most of my life in sort of the lumen, and I've made my way up the GI tract, and now are trying to stand where the liver and the GI tract interact. And so this is very much a place that I feel comfortable with. So how is the inflammatory bowel disease connected to PSC? As you know, about 3 to 5% of individuals with ulcerative colitis have PSC. The range is a little bit sort of, in some studies, even in Japan, it's been much higher. Elsewhere, it's lower, but it's roughly, we would stay in the 3 to 5% range. And the other way around, 70 to 80% of individuals with PSC have ulcerative colitis. Some studies vary, as mentioned, and there may be some geographic variation. It's principally, though, ulcerative colitis. There is an association with Crohn's. Some studies have suggested it's as much, but most, it's much less. And of those people who have IBD, about 80% with PSC and IBD have ulcerative colitis. About 15% have PSC, with PSC and IBD have Crohn's disease. And then about 5% have indeterminate colitis, meaning we're really not too sure. There's some elements that look like Crohn's, some elements that look like ulcerative colitis. But even in those individuals who have Crohn's, it tends to be not just ileal disease, where some people can have it the last part of the small bowel, but it's usually more of a colonic involvement. Sometimes PSC can occur before IBD, but that's less often. And more often, it is something that happens after the IBD has been established. So then the question is are we really lumping things together, or is the ulcerative colitis that's seen with PSC the exact same disease, or are there distinct characteristics? And when we look at it, the characteristics that aren't unique but are somewhat distinct as a group is that the ulcerative colitis that's associated with PSC is more often pancolitis, the whole colon's involved, as opposed to just, say, the rectum, just the left side. It's the whole colon. And about 25% will have a little bit of very mild inflammation in the ileum, though, the last part of the small bowel. Not enough that we would call this Crohn's. It's more sort of a superficial, mild inflammatory response. But that seems distinct as well for what goes on in the PSC-associated ulcerative colitis. And then what's also distinct is that about a third will have what we call rectal sparing. So usually with ulcerative colitis, we think of this as starting in the rectum. It may be the rectum and the sigmoid. It may be the whole left side. It may be the whole colon. But you don't have sort of a little bit higher up. The rectum is almost always involved. The ulcerative colitis that's associated with PSC sometimes does not have the rectum involved. So why that is, we don't understand, but that seems to be something that's distinct, at least in some people. And again, as I mentioned, even those with Crohn's have more often a colitis as opposed to just an ileum. There is, unfortunately, a greater risk of colon cancer compared to ulcerative colitis without PSC. And so we certainly recommend annual surveillance, as you'll hear elsewhere in this conference. But having said that, even though there are some superficial or some significant differences between the nature of the ulcerative colitis that appears in with and without PSC, when we look at very detailed studies, some of which our group has done, some of which others have done, and saying, is there fundamentally a difference? Is the nature of the genes on a very submicroscopic level different? And there's really some very subtle differences And overall, it seems to be, at least in terms of the process of the disease, to be very much the same disease. And so we'd say that this is likely that it may express itself slightly differently. And it tells us something important that we haven't understood yet, but it's likely not a distinct or separate disease altogether. It's probably the same thing, just a minor variant. And often we can't tell the difference. We would say that one of the differences, though, also is that clinically it can be somewhat milder, but still there can be, meaning fewer symptoms, but still there can be significant significant involvement of the colon. So if somebody has IBD, how does that influence PSC as opposed to somebody who doesn't have IBD and just has PSC? So as mentioned, the GI symptoms can be a little bit milder. Getting the GI disease under control doesn't have a significant impact on the liver disease. Having said that, there may be actually an inverse relationship between ulcerative colitis and PSC, so that worsening colitis seems to be associated with milder liver disease. That's not entirely clear, but that's been some interesting observations, at least in one series. So those undergoing liver transplant actually had milder colonic disease, so you'd think they would go in tandem, but this was different, that those who were undergoing liver transplant, the GI disease actually seemed to be quieter. There seems to be, within IBD, those with Crohn's disease tend to have a milder outcome when we measure these in the most severe end stage kinds of measurements, cancer, transplant, or death, that Crohn's disease seems to be milder than ulcerative colitis. Now, that may be in part because the PSC that's associated with Crohn's disease tends to be more small duct disease than the large duct disease seen in PSC and ulcerative colitis. And perhaps, and that certainly has a milder outcome. So it may be not so much the Crohn's as much as the small duct versus large duct disease that's there. So that we were talking about how IBD influences PSC. Then the other side of things is, how does PSC influence IBD? So as mentioned, there is perhaps a slightly different clinical presentation for PSC IBD than PSC alone. Perhaps there's a little bit more both intrahepatic, meaning the ducts within the liver, as well as the extrahepatic, so ducts outside the liver, than in PSC alone. But when we look at a really microscopic level, does it look differently? Does it seem to be behaving any differently? There really isn't a difference. And is there a worse outcome? Perhaps people with PSC and IBD are more likely to need liver transplant than people who have PSC alone. So suggesting that there may be some impact there, but overall it's mild, but perhaps those with IBD are more likely to need liver transplant or more likely to have progressive liver disease than PSC alone. So what happens in that severe case of people who are unfortunate that they need a colectomy? They need to have their colon resected, and they have what's called a J pouch, the last part of the small bowel is turned into a J and put where the rectum is. So you'd think that is a sort of we're almost taking that whole component out of the equation. The colon is gone, there still is a J pouch, but those undergoing a colectomy, it does have a slight moderating influence on PSC, but very mild. It's not as if it shuts down. It really seems as if the PSC largely has a life of its own. Now, those undergoing liver transplant and colectomy together have a lower chance of recurrent disease if you're sort of resetting the whole thing. But that's a fairly uncommon situation. On the other hand, those who have PSC and have a colectomy are more likely to have pouchitis or inflammation in the pouch than people who don't have PSC and have a colectomy. So there's an influence there in both directions, both in terms of ulcerative colitis influencing PSC, though mild, and PSC influencing inflammatory bowel disease. Overall may be milder, but certainly something like pouchitis can happen more consistently in people with PSC. So how about what's the impact of the therapies? If you're using a therapy for inflammatory bowel disease, how does that influence PSC? Well, it's curious that essentially, and it's very frustrating, deeply frustrating, as you know, none of the therapies that are effective in IBD work for PSC. There's no benefit to PSC for infliximab or Remicade, adalimumab or Humira, vedolizumab or Entyvio. We haven't seen any positive data yet for some of the newer agents, such as Xeljanz, Rinvoq, just recently approved for ulcerative colitis, or Stelara, but some preliminary data, there's no, the preliminary data is not supportive of an effect. There is a suggestion in a retrospective study from Sweden suggesting a possible benefit of 6-MP and azathioprine in terms of progression to liver failure, but soft data. And there's a possible benefit, interestingly, of sulfasalazine. So sulfasalazine was sort of the mother of all mesalamines in two retrospective series, one from Japan and one from ourselves at the Brigham. And we have that as a poster you can see. And it's in part because the way the sulfasalazine is metabolized and gets to the liver, whereas mesalamine doesn't seem to be effective, though they're very closely related because that's metabolized in the lining of the intestine. Now, the benefits in both our series as well as Japan were sufficiently great that a clinical trial is underway to see if there may be a therapeutic benefit. And if there is, then that's something that is here and now and can be used. And we've enrolled about 17 patients. We're hoping to enroll another 10 and complete that in the next 6 months or so. So it's curious then in terms of the controversy over vancomycin or other antibiotics in PSC, because antibiotics are commonly not effective in ulcerative colitis, though there's a little bit of benefit, a little bit of data from the PSC data to suggest that maybe there's a mild benefit of vancomycin in PSC, but for the most part, it's not something that is a dramatic agent that will produce remission. So we'll review these questions in a little bit. So then the question really comes together in a fundamental way is how is PSC and IBD connected in terms of the fundamental questions of pathophysiology and disease factors? So there's some genetic differences, but genetic influence appears to be overall weak. Of the primary genes, we'll talk about this a little bit more shortly, about 50% of the genes that seem to be important in PSC don't overlap with IBD. So there's some distinct genetic factors, but some do. So similarly, there's a connection there, but also something that's distinct and different. And this genetic influence overall, even at best, is pretty weak. So what are some of the possible hypotheses about how these are connected? Well, one is this concept of a leaky gut, that bacteria in the colon increases the intestinal permeability. Toxic compounds may cross the liver, cross the intestine, get into the liver, and cause these problems. That certainly could be the case. You'd think then in part, though, that a colectomy would have a broader impact, but that hasn't been shown yet. The question is whether there's some lymphocytes or white cells that get activated in the gut, in the GI tract, and they have a similar binding site, and they, for whatever distinct reasons, they cross-react then with something in the liver. And as an autoimmune disease, is there then cross-reactivity in both? Well, perhaps, but you'd think then if you have something that's going to settle down the gut, you'd think that would settle down what's happening in the liver with whatever, whether it's infliximab or other types of medications, and lots of other immune modulators that have been tried in liver disease in PSC hasn't worked. Question, sort of a variant of the leaky gut, is there a bile acid metabolism in the colon that leads to a toxic aberrant metabolism influencing the inflammation in the colon and the liver, so that there's increasing interest in how bile plays a role in ulcerative colitis, and can be an anti-inflammatory or pro-inflammatory? And is there a distinct type of bile that's off in ulcerative colitis that may influence PSC? We don't know that yet. But there's a great deal of interest in that. And there's even tests being done, studies being done of certain type of bile acids to treat ulcerative colitis that's going on. And much of the blood supply from the liver comes from the intestinal circulation. So how do we try to understand PSC? We look at genetic, microbial, environmental clues, coffee maybe, but very mild in association. Tobacco after quitting smoking, there's a higher risk of ulcerative colitis than never smoking after quitting. Former smokers have a lower risk of PSC. So a little bit different, but smoking still has that same kind of impact. Why is that? Antibiotics as a risk factor before can increase the risk of ulcerative colitis and Crohn's, maybe PSC. But how do we put this together in some ways to make more sense of it? So the most important clue is this link, and how do we get at that better? And just to wrap up here briefly with some research issues, is to understand PSC, we need to understand ulcerative colitis. To understand ulcerative colitis, we need to understand PSC. They're both telling us something critical. When we put these together in this broad model, it's very non-specific. And I think this tends to overemphasize some of the genetic factors. And really it's the environment and probably the microbiome that's the most important thing here. And when we look more specifically though, we understand in terms of genetic clues, important, but really overall the link is very modest. And I don't think we should look at genes. Maybe they're going to teach us something, but that's not the primary link. And that also may be a secondary modifier or response to injury. The microbial clues are probably the most important, at least where many of us are looking now to try to understand. There is a reduced biodiversity and microbial diversity in PSC and ulcerative colitis, but there's a distinct microbiome overlapping with ulcerative colitis, but still distinct in PSC. Understanding what they're doing exactly is a good deal of what we're trying to do. And see whether we can understand that better, and they're distinct bacteria, but what are they doing, and are they fundamentally causing disease, or are they a result of the disease? And then therapeutic clues. Why are the medications that are effective in inflammatory bowel disease not effective in PSC? Does this infer that the immune reaction in PSC is different? Is the nature of the injury different? Or is the nature of the immune response and how the liver responds to this injury different? And are we looking at PSC in the wrong framework? Is it not really fundamentally an autoimmune disease? Or is there something else that we need to learn about the disease? And then lastly, there's probably not a single cause. Both of these diseases, even more so in PSC, probably has an overlap of 4, 5, 6 different factors that need to come together to make this happen. So what are our steps forward? We need to increase the crosstalk between those that research in PSC and IBD, and that's something that we're very involved in and trying to do. We need to recognize that these two diseases are interconnected in terms of fundamental cause, but what's the nature of that, and how do we understand that? And we need to appreciate in a fundamental way that the medications that can help in ulcerative colitis don't help in PSC, and why is that? And that will hopefully give us some clues to develop better therapies and really focus our research as well. Tremendous opportunities lie ahead, and I look forward to discussing this more as the conference goes forward. Thank you very much. Well, thank you all. I really enjoyed those talks and eager to have some discussion now. Now joining us is Joel Pekow, a wonderful person, clinician and researcher and associate professor at University of Chicago. Joel, like myself, approaches PSC from the IBD perspective and helping to bridge the gap between that liver perspective and the GI perspective. He was in medical school at University of Illinois, then came to Massachusetts General Hospital, where we overlapped briefly. After his fellowship at University of Chicago, he stayed on there where his research is focused in on IBD, colon cancer, as well as PSC, and investigating both fundamental issues of pathophysiology as well as clinical issues. And he'll be moderating our session. I just also want to take a moment to introduce Kirsten Muri Boberg, who's joining us as Tom Karlsen was unable to join us at this moment. Dr. Boberg is a leading clinician researcher at the Norway PSC Research Centers, involved in research with biomarkers, cholangiocarcinoma, as well as natural history studies in PSC. Welcome, Dr. Boberg and Joel, and I'll turn it over to you, Joel.
Thank you. It's a pleasure to be with everybody today. I'm here to moderate the session with these great investigators. We have some excellent questions in the Q&A, and I'll try to get through all the questions. If questions come up, please type them in, and I'll ask our panelists. If I don't get to them, it's not because they weren't great questions, it might be because I didn't read them or we run out of time here. But I'll start with Dr. Green. There's a question about collagen specifically, and yesterday there was a talk where a speaker mentioned the potential therapeutic potential of collagen, and you mentioned that collagen is involved in fibrosis. And can you reconcile those differences?
Well, scarring, scar is mainly made out of collagen, and scarring is a natural response of the body to any form of injury. And in liver disease, as in many other organs, it's kind of a balance between laying down collagen, laying it down in the wrong place, and dissolving the collagen or degrading it with, TIMPs, which are a class. So it is true that the balance between the two and where you put it are probably fundamental to abnormal scarring in any liver. In any organ. Now, in any liver disease, you do get cirrhosis or scarring, but often as a secondary effect to like viral hepatitis. In PSC, the primary abnormal scarring is in the large bile ducts or intermediate bile ducts, and you get secondary collagen deposition abnormally throughout the liver.
And Dr. Boberg, there was a question, and this has come up frequently. Many researchers use animal models in studying PSC, in particular the MDR knockout mouse. Can you talk a little bit about the limitations, or not even the limitations, how well that replicates human PSC, and are there other alternative models to use? And then you may be able to speak a little bit also about what Dr. Karlsen was mentioning about novel models of PSC using human tissues as well, and what you see as the most promising going forward.
Well, thank you. We have always, been missing the perfect animal model to study PSC. So what we have to use are something that is similar, but of course that makes a real comparison not ideal, but we can learn maybe elements from studying these animals. It will never be perfect, as I mentioned, but we can maybe learn bits of the puzzle to put together. And you were asking about then
Dr. Karlsen in his lecture mentioned some novel models of PSC using organoids or other ex vivo ways to study PSC. And what do you see as the most promising of those?
Well, you heard he mentioned the bile duct on a chip, where we can put different kinds of cells into, and then study effects of external factors on that. Of course, that is not as a human bile duct, but we can learn elements that may be promising for the future, that can give us hints what to study further on. They can learn some parts of the mechanisms.
Thank you. And Dr. Green, there were a few questions about PSC recurrence after transplantation. Can you shed a little light on how common that is, and do we understand completely why some patients have recurrence and some don't? And there was a specific question, a third part to this, is can you have large duct PSC and have small duct recurrence after a liver transplant?
So most autoimmune diseases of the liver will recur with maybe about 20%. The difference is in PBC and autoimmune hepatitis, the chance of getting progression to where you may need another liver transplant is considerably lower than people with PSC. So there, to my knowledge, is no great way to identify a priori who will run into trouble with recurrent PSC. And we do screen patients both occasionally with liver biopsies and with imaging, but there's no great factor. Perhaps we had discussed colectomy, but there's no clear factor that prevents it. And you have to realize that people with liver transplants have very significant immunosuppression. So even in the face of the large amount of immunosuppression, you still get a recurrent disease in a significant minority of patients. Was there another aspect? I'm sorry.
I think the other question was is it possible to have large duct PSC and then have a transplant and have small duct PSC after the transplant, or when it recurs, it typically near the initial diagnosis?
I don't know the actual incidence of that. Perhaps some of the other panelists do.
May I add, we are doing a large study now. We have been sampling liver tissue, liver biopsies, and done MRCPs for after liver transplantation. We don't have the results yet, but I think that is an opportunity to be able to study PSC from the start, from the very start, where you can find histological changes and then compare how these manifest themselves by cholangiography. And I think this is a unique opportunity. We are working on it. And then, of course, it depends upon how you define recurrent PSC. Maybe it starts by microscopic changes, and then you will see these cholangiographic changes that are more rough changes in the long run. And maybe we can also study the effect of the microbiome, which is very popular now, as you have heard, on this process. There is a lot more to learn, and maybe we can learn things about the early start of PSC. I hope so.
So thank you. And Dr. Korzenik, you mentioned in your talk a little bit, and taking what Dr. Boberg just mentioned, the role of the microbiome in PSC and in IBD. And there were a few questions. One, can you expand on that a little bit? The why we think the microbiome may be important in PSC development. And two, the role of, there's a few questions about the what you mentioned in your talk about the role of antibiotics in treating PSC as well.
So it's a really central question, and currently we want to be cautious because we feel right now everything in medicine seems to be related to the microbiome. But in PSC and in IBD and ulcerative colitis, we really have identified distinct differences, or what we call a dysbiosis, in IBD, in ulcerative colitis, and then even more so in PSC. And so trying to define not just what bacteria are present, but what they're doing is the challenge, so that if the human has about, let's say, 30,000, 35,000 genes, the gut microbiome probably has about 2 million genes. And so as the Norway Center and others have done, we're engaged in a very large set of projects where we're doing what's called whole genome sequencing of the gut bacteria and trying to understand what they're doing. We also think that the oral microbiome may be very critical. And also trying to understand the bile microbiome. So the genetic influence is perhaps 15 to 20%. It's critical to understand, but it may not be the central factor. It may be more of a modifier of why a mild disease turns into something that's chronic. And so I think that it's also trying to understand the microbiome from distinct perspectives of hypotheses. So we have a particular hypothesis linked to a therapy that we're launching shortly, and of a particular toxin that the bacteria might be producing. So I think that understanding that is really a challenge. So one of the questions I know is about vancomycin and an antibiotic. Is that effective? Well, certainly There's studies to suggest it reduces some of the liver tests as markers of reduction of injury. It's controversial, as everybody here knows, and when we've looked at longer term studies, that doesn't seem to have an impact. And probably many of us, I certainly have some patients who have been put on vancomycin more for their GI issues, and despite that, developed PSC while on vancomycin and progressed. And so the question is there a benefit? And then importantly also, even if there isn't a fundamental outcome that differs, what does that tell us? What is the change? The vancomycin is a fairly blunt tool. And how do we learn from that to say, can we refine that better? Is it what we're doing is giving a particular scavenger that binds to that toxin and pulls that out of circulation and may improve the liver injury and hopefully address what may be fundamentally causing it? What other people are doing, and we're looking at that as well, is can you alter the microbiome in different ways? So we did a study with fecal transplant, but again, we need to understand better what is the dysbiosis so that when we try to change it, we have an informed and educated way of trying to say, here's where we are, this is the dysbiosis, and this is where we want to get to. So vancomycin is one pathway possibly, but I think we want to be able to be more specific and more helpful along the way, and that's part of what our center is engaged in. Thanks.
I want to expand a little bit about what you had just mentioned and a couple follow-up questions. One is for Dr. Green here is often is Dr. Korzenik mentioned that LFTs oftentimes improve on vancomycin or even other therapies. Does the improvement in LFT liver function test abnormalities, does that portend to long-term outcome improvement as well, or is there a disconnect?
Well, there may or may not be a disconnect. Obviously, when the liver tests get better, we feel better. And much of the time, you actually do change the natural history of the disease, but not always. And for instance, in primary biliary cirrhosis, which is kind of a cousin of PSC, what the FDA approved was kind of a surrogate marker to study this disease and therapies using the alkaline phosphatase level about 1 2/3 normal. So in many diseases, certainly viral hepatitis, autoimmune disease, acute liver failure, the liver function tests correlate pretty well with ongoing injury and progressive liver disease. In PSC, although we certainly feel better when the liver tests get better, it's less clear whether you're actually changing the ultimate outcome of the disease.
Okay, thanks. And then to expand a little bit about this microbiome theme here, this is a question for Dr. Boberg, or Dr. Green can answer as well if you know the answer. Are there groups or studies that have been done where they've transplanted or given fecal transplants to animals from human PSC patients to look to see the impact on biliary duct fibrosis and inflammation?
Maybe you, Dr. Green?
I'm not familiar. Yes, I actually think there are. The problem is, particularly with mice, is they tend to revert back to the microbiome, often of the facility they're grown in and raised in. And actually different institutions have different bacteria in their mice. And that's part of the reason you can get different experimental results, even when the same experiment is done. So I'm not aware of any data where they've done it and there's been persistent PSC microbiome. Perhaps Dr. Josh can say something.
So in terms of, trying to understand what really is the difference and what is the nature of that difference is a question. So one target has been certainly bile. And some aberrant bile that may be injurious, and trying to use mice is a challenge because, as was pointed out yesterday, there's a particular, there's a uracolic acid, which is more specific, but trying to use an animal model is difficult. We're looking particularly at hydrogen sulfide. We think that it may be that these are connected diseases, but separate, because one is a dysbiosis that is distinct to the colon, and one is that for whatever reasons that microbiome impacts itself higher up in the small bowel and in the liver. So, it's trying to understand what's the nature of the dysbiosis, the nature of the bacteria like Veillonella that are particularly important producers of hydrogen sulfide, which in the body does all sorts of wonderful things. In the lumen can be much more sort of harmful and injurious. So trying to understand that, I think approaching it with a set of hypotheses that are bound to those bacteria are critical, so that we're not just saying, well, some are up or down, but testing specific hypotheses so that we can see if we can direct things towards therapies down the line.
Two groups.
I'm
sorry.
There are also,
Go ahead.
sorry. There are also germ-free animal models that are quite interesting, where you can, they are free of germs. They are raised in that way, and then you can introduce in a systematic way different kinds of bacteria or microbiome and study what happens. That is also a supplementary way to study this.
Two groups have recently what they call humanized the bile, where they remove the enzyme that makes the uracolic acid, which is a healthy bile acid by mice. And unfortunately, those mice got very sick very quickly, just spontaneously. So again, it's not as simple as humanizing the bile to look at this.
Interesting. And Dr. Korzenik, there's a couple questions about the diagnosis of IBD in the setting of PSC, and if a patient initially is diagnosed with PSC and they suppose they have a colonoscopy and they don't have IBD, is there a chance, or is there a likelihood that they'll subsequently develop be diagnosed with IBD? And secondly, in patients who didn't have IBD before transplant, is there a risk of developing inflammatory bowel disease after transplant?
So really interesting, but a very important question. So that more often it's that somebody has IBD first and then they develop PSC subsequently. There are certainly cases, and it can happen the other way around. In terms of post-transplant, if they didn't have it before, it's been described, and it's a little bit puzzling because even outside of PSC, that there are a set of people who undergo transplant for other reasons, not related to IBD. They don't have IBD and they don't have PSC. They have a transplant for a solid organ transplant. They go on immune suppression and they develop IBD after. So why that isn't clear. It's not a very common occurrence, but it certainly is described, and I think we've probably all seen more than a few people with that. So is it a dysbiosis, a change in the bacteria? Does it have to do with actually immune suppression? Even though we use immune suppression, there's some evidence that Crohn's, at least, less ulcerative colitis, may actually be due to it's a paradoxical and it's confusing, so I'm hesitant to just mention it in passing, but actually immune deficiency. So is that what's happening? So it's yes, you can develop it after transplant, but that's uncommon. And more often you'll get PSC after IBD, but occasionally it happens the other direction.
May I add that at least in our experience, some patients who have IBD before transplant procedure, they may worsen after the transplantation, even though they are on immunosuppression, which is kind of paradoxical. Yeah. That is a phenomenon we have observed, and others, I think.
Yeah, I think that's common. That's a clinical conundrum in treating, because the patients are already on immunosuppression, and you're adding more therapy directed towards their IBD as well.
You get a new liver, but you may lose your bowel in the end.
And then another question here, and anybody can take this, is and this is kind of extracted from or from how we observe Crohn's disease as well. We know that Crohn's disease over time, not seen commonly in PSC patients incidentally, but Crohn's disease patients who have longstanding inflammation will develop fibrostenotic strictures in their bowel. And we oftentimes will tell patients that once the scar tissue is developed, the therapies aren't going to be effective for treatment. So one question here is that many of the therapies that have been studied in PSC are given once fibrosis is already developed, and are we missing potentially effective therapies, or are we giving treatment too late and when the scar tissue isn't reversible?
The problem is it's hard to know how long someone's had an asymptomatic disease. And screening serum alkaline phosphatases are not routinely done in the general population. So it's quite possible by the time we see through an ERCP, or more commonly MRCP, gross injury and stricturing of the bile duct, that might be a relatively late finding compared to what had happened 5 or 10 years before.
And just to build on that, I do think that there's a phenomenon that happens where with more strictures, there's probably more stasis, meaning the bile is sitting there longer, and so that there's likely a very important set of differences between early disease and later disease, so that later disease may sort of cycle on itself. And so that those therapies, as the person asking the question rightly points out, may be more effective early in the disease, and it may be that there are a set of other problems that develop. It may be still somewhat effective if the same process is driving it, but it may not be as effective. And I do think, though, that as was pointed out by Dr. Green, that I think what's happening, at least in the IBD world and in Crohn's, is that there's a tremendous number of opportunities for therapies that are being developed or looked at as anti-fibrotic or actually reversing. And similarly, in the liver, not just in PSC, but there's a tremendous amount of interest. We're doing some studies now in mice and in animal models of scarring to see if we can reverse that with some agents and repurposing the special delivery system. So I think that in the years ahead, there'll be tremendous opportunities to reverse the fibrosis. The question is then we still have PSC, and we need to then find a way of treating the underlying problem.
There's a couple questions here about the cancer risk in patients with PSC. And I wonder, first of all, I'll go to Dr. Korzenik, see if we can talk about the risk of colon cancer. In particular, talk a little bit about what a diagnosis of dysplasia means, and what in patients with ulcerative colitis or Crohn's disease, are there other individual risk factors that pretend to give patients a higher risk or a lower risk of developing dysplasia or colon cancer?
So when we look at people with IBD, and particularly ulcerative colitis, when we look at all comers, we worry about this. And typically we'll say if somebody doesn't have PSC, well, it's after someone's typically had significantly active disease for 8 to 10 years. The first 10 years, we might do a colonoscopy every 3 years, then every 2 years, after 10 years, every year after a year. But really what it seems to be is that the most important risk factor, even though there's some early onset, pancolitis, the whole colon involved, probably the most important thing is active inflammatory bowel disease. So that, say in the British guidelines, they will be as if your colonoscopy is totally normal, they would say you can expand your interval to as much as every 4 or 5 years. Now, with people with PSC, we worry about the risk much sooner. They may have also had asymptomatic disease or minimally symptomatic for a longer period of time. But aside from all those things, there's still an increased risk. And so we really recommend annual screening. We're trying to pick up something early. So dysplasia is not cancer, but it's a precursor, some abnormal architecture of the cells. High-grade dysplasia, we typically would consider colectomy. Low-grade dysplasia is a little bit more controversial, and this is an area that Joel's very involved with as well. And so certainly, even though you're moderating, feel free to comment, but I think that it's something that we can do something about. And so we want to screen frequently. We often use something called chromoendoscopy. So it's another technique of picking up dysplasia early to prevent it from turning into cancer.
Thank you. And then Dr. Green, can you talk a little about the risk of other cancers, in particular cholangiocarcinoma or gallbladder, pancreatic cancer with PSC? And are there risk factors in patients with PSC or IBD that portend to a higher risk?
You know, cholangiocarcinoma is a very rare disease in the general population. And it's usually often called what we call intrahepatic cholangiocarcinoma, which is quite different than that related to PSC. So this is the one at least I think, cancer patients worry about the most. And first of all, most patients don't get cholangiocarcinoma, but it may be as high as 15 or even 20% over their lifetime, certainly 10%. So we don't know the exact reason. And typically, most people will do an MRCP or an MRI with a special protocol to screen for it once a year. But PSC patients are particularly susceptible to cholangiocarcinoma at a much higher risk than the general population, because it's basically a pretty rare cancer. Again, the reason why they get cholangiocarcinoma is unclear, just like the etiology of PSC.
Thank you. A question here, maybe Dr. Boberg can try and address this, or anybody can jump in. Is there any insights or any progress in non-pharmacologic treatments for PSC, in particular diet, in mitigating risk or progression of PSC?
I can mention what Tom Hemming Karlsen mentioned in his talk, that is vitamin B, B6 supplementation, which we are going to make a trial on. And if you could call that, that's kind of non-medical, I would say. That is at least one way we can try to explore something.
And I just add, I think what Dr. Boberg probably didn't get an opportunity yet to see it. We've done a small pilot study of 20 patients where we randomized them to a low protein diet versus a high protein diet. So something called the specific carbohydrate diet versus a low protein vegan diet, with a particular hypothesis in mind with what we were talking about with this hydrogen sulfide. Now we did it really, it's so small, just 10 and 10 people on either side with PSC, with the anticipation of really wanting to explore the impact on the microbiome. And to our delight and surprise, we found a statistically significant reduction in alkaline phosphatase and in the other liver enzymes. It wasn't due to carbohydrate intake, it wasn't due to fat intake. We're in the process now of the next stage where we're looking at the microbiome and trying to understand the changes there, and then certainly want to follow this up. But we're excited, not necessarily as prime therapy, but at least as something that may have an impact on the disease. It's obviously very early. It was just an 8-week study, so that we're not sort of suggesting that we would recommend this diet at this point, but at least it suggests that perhaps in understanding the injury, there may be an important role of diet.
All right.
And then Dr. Green, is there any role for coffee in PSC?
Coffee and liver disease, coffee probably is a small factor in benefiting the liver to prevent progression of liver disease in many types of liver disease. Again, you have to drink 4 cups of coffee. You don't do it as a treatment, but if you like coffee, it's good. Again, it's a relatively small effect in all forms of liver disease. I don't know if coffee has been looked specifically in PSC, but certainly there is some beneficial effect of large amounts of coffee in a whole host of liver diseases.
And it seems to be the case for PSC. And it's interesting, there was an article that came out last week, I think, showing that coffee reduces all-cause mortality. Now that was in people who were taking decaf as well as caffeine. And so for liver disease, it may be the caffeine. But for other things, it may actually be polyphenols, which are part of like the berberine that was talked about yesterday, and turmeric or curcumin, which has been looked at and didn't seem to be beneficial in PSC. But it may be that there are other effects that we can understand from coffee and see if there's a benefit.
Another question here, kind of linking the environment to disease pathogenesis, involves epigenetics. And one question was, are there any epigenetic studies highlighting a link between gut and liver in PSC patients to see if there's comparisons? Does anybody know of any results from those studies, or if anything has been published?
Well, we saw, oh, go ahead, Kirsten.
No, I was just about to say that we have worked with epigenetic changes in bile, but that is not the same area. But that has been interesting to try to look for early markers of malignous cholangiocarcinoma development. That's one way to use epigenetics.
And yesterday we saw a very interesting poster presentation by Henry Pratt on epigenetics in the liver, not so much connecting GI up to the liver, but just suggesting there may be important changes that could give us some important clues.
Excellent. And then I'm scrolling through the questions here, trying not to miss anything important. Dr. Korzenik, you mentioned, this is going a little bit of a different theme, or you mentioned the risk of pouchitis is higher in patients who have a colectomy and have an ileopouch anal anastomosis. Is that risk, is there any data if that risk goes down after a transplant, or is it irrespective of a transplant?
No, I'm not aware of any data that shows that. Keep in mind, we're getting smaller and smaller numbers of patients in these studies. So someone who's had a transplant, and then someone who's had a transplant and pouchitis. So it's getting a little bit smaller to look at that, and even looking at, so that's harder. And I think that it may, though, indicate again what we're talking about in terms of a more severe dysbiosis that may be critical to the whole process. I think maybe we have time just for one more.
One more question. Okay. It's got to be a good one. I'm trying to find something great here. I got a question here about the fatty acid DHA, which is a component of fish oil, that was studied in the 90s. Is that been explored any further? Is there any thoughts that that may be an effective treatment?
I think so. It was studied, it was very hopeful, some studies in IBD, but very large studies in Crohn's, 2 large studies failed to show something. I think there still may be something there, and it's something of interest, but I don't think it's going to be a major therapy. It might be a minor adjunctive therapy.
Okay. I apologize if I didn't get to everybody's questions. I tried to hit a broad area here, but I want to thank the panelists for their time and excellent talks. And I hope everybody enjoys the rest of the conference.
Great. Thank you, Joel, very much. And thank you, Dr. Green, Dr. Boberg, very much. We'll have a 10-minute break. And then following that, we'll have breakouts to discuss a number of important, both our grant program and also hearing the voices of PSC patients, caregivers, researchers, and all other attendees. And so we will see you soon after the break. Thank you very much.